Well, good morning, everyone. Wanted to thank everyone for joining us this morning. Our Northwest MHTTC webinar on stigma reduction among people with HIV to improve health outcomes. On behalf of the Northwest Mental Health Technology Transfer Center, I'd like to welcome everyone to today's webinar. I'm Lydia Chwastiak. I'm the professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington and the co-director of the Northwest MHTTC. And we're very excited to bring this webinar to you and with our expert presenter, Dr. Deepa Rao, addressing stigma reduction for people with HIV. This 60-minute webinar is sponsored by the Northwest MHTTC. So wanted to let people know what the MHTTC is and what our MHTTC network is. The network is a nationwide network of training centers that is supported by SAMHSA, funded by SAMHSA, and our purpose is to disseminate and support the sustained implementation of evidence-based practices for mental health disorders, and to really support the behavioral health workforce. As I said, it's a national network. There are regional centers. We're up in the Northwest, Region 10, and then the National Coordinating Center is based at Stanford in California, and then there's a National Tribal Affairs Center and a National Hispanic and Latino Center. And together, this collaborative network supports resource development and dissemination, training and technical assistance, and workforce development in the mental health field throughout the U.S. The Northwest MHTTC, as I said, is based out of UW in our Department of Psychiatry. We provide training and technical assistance in evidence-based practices to the behavioral health workforce. So that's behavioral health providers, primary care providers, school mental health staff, social service staff, anyone whose work has the potential to improve behavioral health outcomes for people who have or are at risk for developing serious mental illness. And broadly, our goals are on the next slide. They're on this slide, to heighten the awareness, knowledge, and skills of the workforce, to accelerate adoption and implementation of mental health-related evidence-based practices, and to foster alliances among culturally diverse mental health providers, policymakers, family members, and clients. It is our intention to always be mindful of using language that promotes recovery and culturally appropriate terminology. We encourage all clinicians to use a person-first language. This emphasizes the individual, not the condition or the disability. Person-first language is a way to demonstrate respect for a person's dignity and worth. It is consistent with recovery-oriented practices and promotes treatment environments that foster respect, human dignity, and hope. So before we get started, we'd like to take a moment and ask who we have with us here today. We're going to try to run a poll. You should see a poll on your screen, and we really just want to get a sense of what your role is in your organization, just so it will help Dr. Rao understand who she's talking with, and kind of frame the content, just to know whether she's talking with administrators or clinicians and what kinds of disciplines people are working in. So you should see the poll up on your screen, and there's several response options here and the role that you play at your organization. So if you would take a moment to just check a box if you see your role there, and if you are in the other box, many of us are in the other box, just type in your role category in the chat box. Looks like we've got a good mix of folks, with a lot of social workers on the call, and predominantly clinicians, peer support specialists, and a good number of other folks. And looks like we've got mental health care managers, case managers from housing, probation officer, child and youth care managers. So great, nice mix of folks, and thank you all for joining today. We know that everyone's quite busy with a lot of tasks, especially clinicians. So appreciate you taking the time to be with us this morning. So why don't we move on? I'm very excited to introduce today's speaker, Dr. Deepa Rao. She is a professor. She's a wonderful colleague. She's a professor in the departments of global health and psychiatry at the University of Washington. She's a licensed clinical psychologist by training, and her research and clinical work has focused on the implementation of effective interventions to improve mental health and to reduce stigma for people with chronic conditions such as HIV, diabetes, depression, and breast and cervical cancer. Her current projects are both in the United States and globally. Her US work has focused on developing stigma reduction interventions, and her current global work focuses on um, integrating care throughout South African primary care system and also building mental health research capacity. She's also doing some really interesting work in India related to improving access to and treatment of depression among pregnant women who've experienced domestic violence. She's the associate director of the Center for AIDS Research, the Behavioral Science Core. She's associate director of global mental health at UW, and she's also the associate director of the MPH program in the Department of Global Health at the University of Washington. So we're very excited to have you with us, Dr. Rao, and I'll turn the presentation over to you.
Thank you so much, Lydia. Thank you to everybody in the audience. I very much appreciate the enthusiasm and attendance on this session, given all that we're going through here in the Pacific Northwest and in the world. I feel that it's probably relevant to say that what I'm about to talk about in terms of stigma among African American women living with HIV can be somewhat generalized to other infectious diseases like COVID-19 that we're all facing. And many of the theories that I'm about to present and the intervention techniques actually come from stigma reduction among people with mental illnesses. And so there are some things that can be shared across disorder, identity, condition, and in the era of COVID can be relevant to what we're facing today. So I'm happy to answer questions at the end about that. And we thought we'd start with a poll. So I wanted to ask all of you, how many of you are familiar with the concept of stigma? So if you could vote, that would be great. I'd love to get a sense of how much some of you have heard about this topic before. Okay, so it sounds like we got quick results back. Sounds like about 45% of you are extremely familiar. So I hope that what I'm about to talk about is helpful and informative. There's some moderate familiarity and other levels of familiarity reported as well. So thanks for letting me know that. I think we have another poll question next. So the question is, have any of you experienced stigma in some way or another? So, and I'm not surprised, 88% of you answered yes here. Stigma is such a common phenomenon that we find that most people, an overwhelming majority, and maybe even the 4 of you that answered no might change your minds by the end of the presentation. But most people have experienced some form of stigma. It comes in kind of a less severe form of maybe you're standing next to a person, you tell them that you're not feeling well, they take a few steps back. That could be interpreted as stigma. I mean, in the era of COVID, many of you probably maybe coughed a little quietly because of allergies or something like that, and then people around you take a few steps back. That would be an example of stigma that one might experience. People with marginalized identities can often experience stigma as well. People come from, certain ethnic racial backgrounds or are marginalized sexual orientation statuses often report feeling experiences of stigma. And I will break down a little bit of what I mean by stigma, but it is very common for people to experience some form of stigma in their lifetimes. Whenever I ask the questions that I ask, what is stigma, that sort of thing. Most people know what it is, but I will present to you some definitions. So stigma, according to the National Minority AIDS Council, is a label given based on perceptions of behavior, associations, or the presence of an identity or an undesirable condition. It's also, we psychologists tend to think of stigma as an attitude, because we look at things kind of on a intrapersonal level. And every attitude has three components: a cognitive, an affective, and a behavioral component. So, what I mean by the cognitive part of stigma or an attitude is that there is a stereotype belief. So, an example of this would be a belief that people with depression are dangerous, or people with schizophrenia are dangerous. Um, the affective component would be a prejudicial affect, so just a feeling, an emotion like fear. And then the behavioral form would be the discrimination aspect. So, an example of this is somebody taking two steps back, or somebody keeping their distance from a person with depression or schizophrenia. So, I think most of you understood or heard me say that there are different layers to stigma that interact with each other. The employers, providers, family members kind of perpetuate stigmas that they may have observed in institutions, but they can also feel stigmas. Family members can feel what we call a courtesy stigma, or a stigma by association, if they have a member of their family who's living with HIV or living with mental illness. I can explain this layering effect a little bit more in the next couple of slides. But stigma, as we know, has many negative consequences, including isolation and loss of social support. Stigma associated with HIV has been shown to be highly related to depressive symptoms and other psychological distress presentations like anxiety. Leads to poor quality of life and poor medication adherence. Stigma can isolate people so that they don't come in to see their provider. And that ultimately has impacts on morbidity and mortality. So, following on this idea of this layered approach, if we look at the public level where stigma can originate in terms of within a culture, social norms, power structured, shared beliefs about the body, health, and illness, that can lead to public stigmas, members of the public who perpetuate stigmas, but also institutionalized stigmas, which are policies of institutions that, or even countries that get written into laws and then perpetuate stigmas. These stigmas are experienced by the individual who may internalize them and believe that the stigmas apply to them. For example, a person living with HIV might see the stigmas in their community and then start to believe, yeah, I am somebody who should feel ashamed because I live with HIV. That would be an example of self or internalized stigma. That stigma can be further exacerbated by someone coming from a marginalized racial community. Perhaps they might have a transgendered identity and other statuses that can kind of have a layered effect upon stigma. So these layered effects people have called intersectional stigmas, where different marginalized identities can carry stigmas with them and have an additive effect on the person. Once stigma is internalized, as I mentioned before, a person may utilize treatment poorly, and then that leads to poor health outcomes. In terms of measurement of stigma, there are different ways that you can measure stigma if you're a researcher and are interested in measuring public stigma or attitudes by healthcare workers that they may have that are stigmatizing, or internalized stigma. There are ways to measure how much somebody is stigmatizing themselves. There are also different ways that we can intervene on stigma. So in terms of intervention, we can intervene on the societal level by removing institutional stigmas or policy that may be discriminatory, like our Americans with Disabilities Act. We can also encourage people with microfinance programs to be economically independent, community organizing is a way to reduce stigma on the societal level, and as well promoting contact between those that are stigmatized and others who may be perpetuating stigmas can promote kind of the human side of the person who's living with a marginalized condition. And that is a key kind of intervention technique. In terms of the individual level with self-stigma or internalized stigma, education can sometimes help to reduce stigma, coping skills acquisition, so, counseling. And then most importantly, as we'll see with some of the study that I'm about to present, social support is very important. Contact, having groups is a way to help reduce stigma. I'm going to talk a little bit about a program that I worked with that started with some of the work I did in Chicago, and then moved here to Seattle and has become a national program, where we tested the effectiveness of what we called the Unity Workshop. You can read more about the studies with some of the papers that I have in the slides. Part of what motivated me to do this work was that when I was living in Chicago, I was noting that many women kept themselves at home. African American women who were living with HIV would not come in for treatment. And I started looking at the data and was staggered to find that 66% of HIV infections in women occurred with African American women. And I was learning that AIDS was the leading cause of death for African American women between the ages of 25 and 34. And the death rate of African American women with HIV was 15 times higher than HIV infected white women. So these were devastating pieces of data. And my team in Chicago and I worked very hard to try to develop an intervention to at least, try and have some impact, although the causes of some of these numbers have many different factors. African Americans have the lowest medication adherence rates compared to other US groups. And we were also finding that studies with African Americans living with HIV reported that in order to avoid stigma, people tended to adhere to their medications less. And we found this in some of the groups that we were running in Chicago, that our youth living with HIV would hide their medications or not take them in front of family members or peers because they were embarrassed. And at that time, the regimen was complex and they would have to take their medication multiple times a day. I think now, we have one pill that, the cocktail in one pill that people can take. And so that helps a little bit with some of the complexity. But still, people do kind of, in a sense, they don't want to remind themselves that they're living with HIV, and so they may avoid taking medications. So we were finding at the time that the International Center for Research on Women had developed an HIV stigma toolkit. It was being used outside the US, and some of us working together thought maybe we can adapt the program, the HIV stigma toolkit, which you can still find online, the exercises and modules for this. But we thought we'd adapt it for a US population. And what we did was we developed trigger videos, and I'll try to play an example of this in a few minutes to stimulate discussion and kind of add to this program for stigma reduction. We did some focus group work to help guide the direction of the intervention. So in terms of what the intervention looked like, it's an intervention that runs across 2 afternoons, 4 hours each afternoon. And each workshop contains videos, discussion in groups, and role play in pairs. We also trained a peer, so another African American woman living with HIV, to lead the groups, to facilitate the groups. We also made sure that a licensed clinical social worker was in the room with the peer in case any urgent or severe issues came up. And there were cases where we did have to call in the social worker for some reason or another, when there was a crisis situation. So it was helpful to have 2 people in the room to handle the group workshops. We started, thanks. So we basically established expectations at the start of the group. People talked about their experiences of stigma in certain exercises. They shared coping resources with each other, gave each other as ideas of how to cope with stigma. We practice relaxation techniques. One of the videos that I'm about to show goes through an assertiveness exercise where the women who saw different endings to a way to handle stigmatizing experience, and were able to kind of weigh, well, an aggressive form of reacting, a passive form of reacting, and an assertive form of reacting to the stigmatizing situation, and role played ways to kind of cope.
My name is Alexandra, but most people call me Alex. I come from a family with 6 kids. I have an older sister, Danielle, and then we have 4 brothers. Or we did have 4 brothers. My brother Jimmy died 3 years ago. My sister Danielle and I are really close. She's always looked out for me. Maybe it's because there's always us against the boys. Anyway, even though we don't live too close together and she's busy with her son, we still talk on the phone all the time. And we try to get together and have coffee or go for a walk at least once a month. So, Danielle, I wanted to get together for a reason today. There's something I have to tell you.
What is it? Alex, you can tell me anything. That's what sisters are for.
Well, this week
What is it, sweetie?
I tested positive for HIV, Danny. I have HIV.
Oh, it's okay. It's okay. We'll get through it together.
I need you to keep it a secret. Do you want to tell Mom?
No, of course not. I'm here for you, Alex. Oh, look, Trey, go ahead and run up to the park. Oh, boy.
So there are 3 different endings here.
Oh, I better take this. It might be about the car we're selling. Keep an eye on Trey.
I'm coming to get you. Here I come.
Yeah. Uh-huh.
Let me go fast. Do we go faster? Yeah? You sure? Fast? Okay. Whoa!
Great. Then we'll see you later. All right. Thank you. Bye-bye. Trey, I need to talk to Aunt Alex for a minute. Alex.
Are you gonna buy the car?
Alex, you are too sick to be running around like that. You need to rest. Take it easy, girl. Go sit down. Let me push Trey on the swings.
Yeah, you're probably right.
Great. Well, thank you for calling, and we'll talk to you soon. All right. Bye-bye. Trey, I need to talk to Aunt Alex for a minute. Alex?
What is it? Are they gonna buy the car?
Alex, you are too sick to be running around like this. You need to take it easy. Take it easy, girl. Go sit down and let me push Trey on the swing.
Danielle, I'm fine, okay? Trey and I were having fun. Can you just let us have our fun, not boss me around for once?
What did I say?
I can explain what happens in the video, and you can watch it kind of on your own as well. These videos are freely available on YouTube. So the last video just shows a assertive way of handling that, what some may call a stigmatizing situation, though mildly, where the 2 women talk through the issue. And so it's not passive, it's not aggressive, and both people in the end win out or gain something from the interaction. The video stimulated, all the videos, there are 4 with the workshop, stimulated so much discussion. We would play the videos, and the women would, there would be about 15 women in each group, would immediately start talking, maybe after a 5-second delay, because they were so excited to talk about what happened in the video, that they had experienced something similar, or that they, had something they identified with someone, oh yes, my sister does the same thing. And so they would talk through it. They were really motivated by the issues that came up in the trigger videos, that they ended up learning a lot through discussion. The Unity Workshop, as we called it, got its name from this exercise called Web of String, where women would toss a ball of yarn to each other and say something positive And then in the end, this web of string was created that had this positive kind of meaning for the women. And one of the women threw out the word unity, that she felt united with the other women there. And so this became the Unity Workshop after a pilot. We did a pilot study, as I mentioned, and that's just a kind of an advertisement for where the study was. And we used a pre-test, post-test design. We measured stigma before the workshop, immediately after the workshop, so in day 2, and then again a week later. And as you can see here, stigma was reduced with the 24 women that participated, but it kind of started to creep back up at day 8. So we thought, maybe we should have something kind of like a booster session that might help women maintain that stigma reduction over time. So in the next study that we did a larger trial of about 224 women, where we ran the Unity Workshop several times in Chicago and in Birmingham. And we used a randomized controlled design where we compared, basically compared Unity Workshop with a breast health workshop, which also used a group format. We found after this 5-year trial was that it was very interesting, actually. The gray line represents the breast cancer control group and their stigma scores, and the black line represents the Unity Workshop participants' stigma scores. They kind of bounced around over time, were reduced around month 8. At month 6, we had a booster session of the workshop where the women met in person again for both the breast health workshop and the Unity Workshop, but for just one afternoon instead of 2. And then we kept measuring stigma, and we find that over time it kind of does go up, which kind of told us a few things, that perhaps there was something about the fact that both groups had, or both interventions had a group format. So the breast health workshop also had a group format, and the women were getting something out of the group. And so we did some other additional analyses and found out that as stigma decreased, the women's social support increased. And as the stigma increased, the women reported that their social support decreased. So there was some real close tie, no matter what group the women were in, whether they were in the breast health workshop or the Unity Workshop, around meeting in a group, increasing their social network, and feeling supported, that helped to reduce their stigma. So there was some reduction in stigma scores for both groups. They shared active ingredients. And we felt that social support was a key mechanism in finding the stigma reduction. The other thing that I did want to mention that's not on the slide is that with the stigma scores going up after 14 months, we thought something more ongoing would be more helpful. So an ongoing intervention would be most helpful to maintain those gains. We then looked at whether or not enacted stigma or experiences of discrimination and internalized stigma impacted the women's viral load. So that is kind of a health outcomes marker for the women living with HIV, that if they were taking their medications and their health was moving in a positive direction, their viral load would be low. We also looked at whether or not depressive symptoms or social support would mediate that effect or be a mechanism through which stigma impacts viral load. So what we did find was very interesting, that enacted stigma or those experiences of discrimination were related to viral load. And what we researchers have found is that it's really difficult to tie these behavioral factors like stigma with biological factors like viral load. But here we found that enacted stigma was related to viral load. So if the women were experiencing more enacted stigma or more discrimination, we would find that their viral loads were higher. So they were more ill. They had more copies of the HIV virus in their blood, in their system. And then the opposite as well, that if they reported lower scores of enacted stigma, so fewer experiences of discrimination, they were more likely to be virally suppressed. And, I just wanted to kind of conclude by saying that HIV stigma is a common is common among African American women receiving treatment for HIV, and enacted stigma appears closely tied to viral load. And although we did not find that social support was a mechanism, our prior study showed that social support was a very important factor in helping to reduce stigma, and that depressive symptoms as well do not seem to be a mechanism by which stigma operates on viral load, but it also is highly correlated in past studies with elevated stigma scores. So depression has been related to stigma in past studies. What are the implications of this? Stigma may predict viral load outcomes or health outcomes in general, and ongoing experiences of stigma may hinder viral suppression. So intervention should aim at mitigating sources of HIV stigma or use social support mechanisms to reduce stigma. And for future directions, we're working in the Deep South with community-based organizations to adapt the Unity workshop for a community setting, so outside of the clinical setting where the Unity trial took place originally. And we're also adapting the tools for men as well as women, so African American men and women in the Deep South, because this is where the HIV prevalence is highest in the United States, is in deep Southern countries like South Carolina and Alabama. And so that work is ongoing and moving forward as actually with COVID-19, we've had to kind of stall some of our progress with that work. We put it on hold, but we'll be moving forward with it. We did all of this work with a team of people and NIH funding. We wouldn't have been able to find the findings we had if it weren't for these teams that were located in all of these different areas in Birmingham, Seattle, Chicago, and I need to acknowledge them. So thank you all. I'll stop here and let Lydia take over. Thanks, everybody.
Great. That was really a terrific presentation, Dr. Rao. I just want to thank you so much. You know, the terrific work in linking stigma, enacted stigma, to viral load is really just the importance of that finding, of being able to really connect it to a biological outcome. And was just wondering if you could say a little bit more about the enacted stigma, what it was, what your thoughts are about, were there particular kinds of, what the enacted stigma, just say more about the enacted stigma, were there particular types of experiences people had, or was there any
Okay,
specific?
sure. Yeah, so enacted stigma was kind of a component of the stigma scale that we used. So enacted stigma on the scale that we measured things like, people look at me differently because they know I'm living with HIV, or I feel isolated, that kind of thing. Which I wanted to also add in this portion that, in this time, which may be a few months ahead of us, where we're social distancing, a lot of our clients, patients, consumers will be feeling very isolated, which would exacerbate the stigma that they might have already been experiencing. And so, although we're social distancing and we can't be in person together, I think the next best thing has been to try to get people together in Zoom groups or FaceTime, things like that. And if that isn't even possible because of bandwidth issues, there are also these applications on the phone like WhatsApp that are helping to bring people together and feel supported by one another. I think that those have been some of the things that I've been recommending when people ask me, well, what do we do to reduce stigma when we can't be in the same room? But we have to simulate that. And I know for me, it's helped. We hear bad news every day these days, and sometimes every hour. And it helps to the social support aspect is so important for people's overall mental health, but also stigma reduction.
I appreciate the comments about the social support and the sort of differential impact on people living with serious mental illness, and wanted to remind people of the resources that are available for additional support. And we'll talk about, kind of links on our website about work that's being done through some of the Washington State peer support services, and just how incredibly important it is for people to support each other. The question that's in the Q&A is related to whether the findings about stigma were only for African American women or for women generally. Has any of this work been done for other groups of women, or is this really just focused on African American women?
Yeah, thank you so much for asking that question. So one of the things that you need to know is for research purposes, to get funded by NIH and actually trial something under careful conditions, we have to make our sample really, really specific. And we need to also look at our outcomes with really, really specific measures. And so we had to limit to African American women living with HIV, just in order to make the trial highly controlled. But the mechanisms that I talked about, and stigma in itself, is experienced by so many people. And as I mentioned before, I mean, all of us experience stigma in some way or another. If it's a temporary condition, like, working through COVID-19 illness and starting to feel better after 2 weeks, we'll feel a stigma in that way. But also, any race, cultural background anyone comes from can experience stigma to varying degrees. And so, in the same way, I think that there are certain things that people experience differently depending on the condition. My mentor from Chicago, Petra Corrigan, has studied severe mental illness and stigma quite a bit. And he argues that mental illness stigma is very different in content than HIV-related stigma, where somebody with HIV-related stigma might feel kind of like, dirty living with a certain condition, or, like someone can't touch them. A person living with severe mental illness may feel like it's their illness is their responsibility, that they're dangerous. So they have somewhat different characteristics, but the consequences are the same: isolation, loss of social support, which is why the intervention is also the same: increasing social support. And sometimes people find that they support each other with their peers, other people who are experiencing something similar. So getting people together in groups is ideal. In-person groups, there's a hierarchy of what social support can help and what can be marginally beneficial. I mean, online chat groups and things like that can be somewhat beneficial, but the best is getting people together in person so they feel like they're reading people's facial reactions and feeling that support and seeing it in their face. I guess it's a good thing to consider as you are probably providing services online at this point, that being able to see people visually is important.
Appreciate you generalizing the response around, to kind of think about other reasons why people might experience stigma. The other thing I was thinking about is your presentation was just about the need for ongoing support, not just the initial workshops, and just wondering, sort of with all the experience you've had in booster sessions and looking at sort of the long-term effects, kind of your reflections on that, about how long interventions how long people will continue to meet, how long it's helpful for people to be supportive, the frequency of connecting, just sort of any sort of thoughts about the nature of that longitudinal support.
Sure. Yeah. Thanks for asking that. So it's impossible to study an ongoing intervention. I mean, grants and research studies that we get are all time limited. But what I've seen in actual clinical practice are great examples of weekly support groups that have been so helpful for people. One example is here in Seattle, Babes YWCA is a network of women living with HIV, and they have an ongoing support group. They have a couple of different ones, but they have one for women where they share lunch together and they meet weekly. I don't know if anybody in the audience is from Babes YWCA, but they're that type of support group run by a peer who's supported in supervision in case anything urgent comes up or any kind of crisis situation comes up is so helpful. There's no end to it. They just provide the service unless, for some reason, they have a hard time finding funding to pay and, be able to provide food for these groups. But even then, my guess is they would still meet, and they're probably meeting now.
Thank you for
Yeah.
mentioning the Babes Network. It's a terrific organization, and I think I'm sure our audience is familiar with them. But it's good to know. I mean, I think just clinically, most of our audience are clinicians, and just thinking about how important in HIV clinical settings or primary care settings ongoing support would be.
Mm-hmm. Yeah.
Well, why don't we go? We only have a couple of minutes left. We have a couple more slides just to thank Dr. Rao again. If people have additional questions, if you want to type them in or email us at northwest, email us at northwest@mhttc.org. We can get your questions answered. So this is how to get in touch with us. Our website is there. We are compiling, the National MHTTC Network is compiling resources just generally to support the behavioral health workforce, but in particular, kind of hot off the presses, updating resources about the COVID respond, the impact of COVID and support for behavioral health workforce to respond. So please go to our website. We're also on social media, so you can follow us on Twitter and Facebook. And then, as I said, you can email us. So if you have questions for Dr. Rao that we didn't get to, please feel free to email those. We do have some additional training opportunities that we wanted to remind you about. Our Behavioral Health Crisis Response Systems live webinar series has 2 webinars coming up. March 30th with Dr. Ken Minkoff will be on designing and implementing ideal behavioral health crisis systems. And then on April 15th, we'll host Dr. Michael Pflaum on the topic of implementing new crisis services, the view from the ground up. So those dates, March 30th and April 15th, they're parts 2 and 3 of the crisis response system webinars. Please look for those. You can find out more about these and register for them, and also additional resources at our website. And if you want to get in touch, please do reach out through email. I'd like to once again thank Dr. Rao for a terrific presentation and all of her terrific work on this important topic, and thank everyone again for joining us today in these uncertain times, and just reminding everyone to take care of themselves and take care of each other, and please feel free to reach out to our MHTTC if there are resources we can provide. So we'll sign off. Thank you.
Yeah, thanks for having me, Lydia.